Hello, everyone. I'm Brandon Staglin, President of One Mind. On behalf of One Mind's board, team, and scientific advisory board, I want to welcome you to the 26th Annual Music Festival for Brain Health Scientific Symposium. Thank you so much for being here with us today. Even though we can't be here in person, I'm delighted to know that you're all here virtually. And I want to extend a very special thanks to the Shear Family Foundation for generously sponsoring this event. 2020 has been a year infused with too much pain, both in the world around us and within ourselves, especially those of us who experience brain health challenges like many of us have. If you felt some of that pain this year, I'm with you. In fact, I think I've grown more gray hairs this year than in all of the past decade. But I prefer to light a candle than to curse the darkness. So even though this year might have put us all through the ringer, please put on your sunglasses, because today you're going to experience a gazillion candle power supernova of hope. Over the last 30 years, I've learned firsthand what it means to live with a serious mental illness, schizophrenia. But over the last 15 years, I've learned from the amazing scientists and advocates that One Mind works with about the brilliant breakthroughs that are changing lives around the world and reigniting my hope year after year. You're going to hear from 5 of those scientists today who are going to dazzle you with their perspectives on the breakthroughs that hold tremendous promise to help people all around the world. You're also going to hear from the scientists about the elevated mental health needs of the pandemic. But what your job today is going to be to ask us questions. Okay, so if you come here to learn more about brain health science and you're curious, and I bet you are, please express your curiosity and let us know what your questions are. We want to build a symposium around you and your interests. But first, I'd like to honor 2 amazing advocates who are changing lives of people with mental health challenges. Today, I'd like to announce One Mind's Inaugural Advocacy Awards.
2020 has been a year of amazing acceleration in mental health advocacy throughout the United States and the world. In celebration of this phenomenon, One Mind is proud to bestow upon 2 amazing leaders in mental health the inaugural One Mind Champion Award and the inaugural One Mind Game Changer Award. Chantel Garrett, on behalf of all of us at One Mind, I'm very pleased to present you with the inaugural One Mind Game Changer Award for your outstanding leadership and innovative approaches to help people facing mental health challenges to lead full and productive lives. Thank you, Chantel.
Wow, this is incredibly exciting, and I feel humbled and honored to accept this award. We are incredibly excited to continue to do work as an online resource hub, as a part of One Mind for young people and their families looking for information, support, and resources related to first episode psychosis and beyond as well. So thank you for enabling this and for recognizing our work. I really appreciate it.
Amit Paley, CEO of the Trevor Project. We at One Mind are so excited to present you with the inaugural One Mind Champion Award. Your outstanding leadership and advocacy help people who experience mental health challenges to live healthier, more meaningful lives. Thank you.
Thank you so much for this award. I am honored to accept it on behalf of everyone in the Trevor Project community, our volunteers, our staff, our board, our donors, everyone who cares about LGBTQ young people. We are the world's largest suicide prevention and crisis intervention organization for LGBTQ young people. And I think this award just reinforces what so many people believe. And I hope what message that this award sends, which is that LGBTQ young people are beautiful the way that they are. They are deserving of love and respect. And most importantly, that they are never alone. Thank you again for this incredible honor. And we're very excited to continue partnering together with you and with One Mind.
And now it gives me great pleasure to introduce our moderator for the symposium today, Dr. Eric Nestler, MD, PhD. Eric is Nash Family Professor of Neuroscience, Director of the Friedman Brain Institute, and Dean of Academic and Scientific Affairs at the Icahn School of Medicine at Mount Sinai. He's also been co-chair of our Scientific Advisory Board for more than a decade and he's led with his characteristic integrity and wisdom. And he's moderated our symposium for many of those years with sensitivity and warmth. Eric, thank you so much for doing this again, and please take it away.
Brandon, thank you. It is a tremendous honor and privilege for me to help moderate this year's Music Festival for Brain Health, sponsored by One Mind and the Staglin family. We are all so sorry that we cannot hold this program in person at the gorgeous Staglin Vineyard in the Napa Valley. It has been such a challenging year in so many ways, as Brandon said, yet our ability to persevere is emblematic of the human capacity for positive adaptation and resilience. Life goes on, as we will demonstrate today. We have an exciting scientific program planned for you, and as Brandon emphasized, we want you to ask questions. Please use the Q&A function in Zoom, and we'll get to as many of your questions as possible. It is now a great pleasure for me to introduce our plenary speaker, Dr. Victor Zhao, who is president of the National Academy of Medicine. Dr. Zhao spent much of his career at Duke University, where he led pioneering research in cardiovascular medicine. We're delighted to have Dr. Zhao join us for today's program. Dr. Zhao.
Thank you very much, Eric. And let me begin by thanking Brandon, Garen, and Sherry for inviting me to this very special event. You know, I'm a physician, a scientist, but I spent years as administrator, as the CEO of Duke University Health System, and the last 6 years I've been leading the National Academy. We care a lot about what happens to the nation, and of course, in this particular area, we care about mental health. I think all of us are here today because we all care about mental illness. And of course, many of us have personal experiences with this disorder, whether it affects ourselves, a friend, or a loved one. My wife's cousins and their children are afflicted with depression, bipolar, and other illnesses. I've seen the struggle. It's difficult, but having the right resources and support, they're doing well. But I think my experience is not uncommon. In fact, we all know that 1 in 4 people suffer in the world suffer from a mental and neurological disorder. So if you look around this gathering, I know it's difficult to do the Zoom piece, but it's clear that everyone will know someone with this condition. We also know how difficult it is to deal with mental illnesses. People don't talk much about this as we do with physical conditions such as heart disease. I'm a cardiologist, or cancer, or kidney disease, because we all know there continues to be stigma associated with mental illnesses, and also the fact that these conditions are difficult to treat. But in addition to my family experience, I have become very passionate about improving mental health. This is based on my years as the CEO of Duke University Health System, watching how we struggle as a system to deal with this issue, and nationally as a country. And of course, most recently, my relationship with Brandon, Garen, and Sherry have really inspired me. They are working so hard. They have showed us the way, and I'm so glad that I'm working with them now, closely together, certainly supporting One Mind, but also on new initiative, which I presume I'll have a chance to talk about later, which is a Healthy Brain Global Initiative. I think it is time for the world to acknowledge the prevalence of mental illnesses. It's time that we get involved to change the current state of mental health care and prevention. That is why this event is so important. Important to get the support that is so much needed for work in brain health. And I'm so optimistic of the future because I know together we can transform this field. But let's first look at the problem. It is a big problem. Mental illness is the #1 cause of adult disability globally, the major disease burden that causes disability. 450 million people and more worldwide live with this. I mentioned 1 in 4 people are affected by mental neurological disorder, 90% of nearly 1 million people worldwide who die by suicide each year have a psychiatric condition. And financially, the global economic burden is $3 trillion annually. It's estimated about 12 billion working days are lost every year due to mental illness. But it's important to point out that mental health is linked to physical health, chronic disease. Majority of people with mental health also have physical illness such as diabetes, hypertension, heart disease, etc. We know that mental health affects people of all ages because, when you're older, you think about Alzheimer's, neurodegenerative disease, but it really starts very early, from young children to adolescents and young adults. And we know there's no one single cause of mental illness. There's a number of causes and factors that contribute to the problem. Biologic factors, well, certainly it's been associated with chemical imbalances and evidence for genetic factors. But I believe that experience, environment is really important. Early adverse life experience, particularly in your childhood, is trauma, history of abuse. And, these experiences have great impact, particularly when you're growing and your brain is still developing. Trauma, physical, emotional, harmful, and threatening, have long-lasting adverse effects. Social factors, the tremendous pressure people live under, the isolation, bullying, and of course the use of alcohol or drugs. And it's been shown that frequent marijuana use during adolescence is associated with increase of psychosis in adulthood, particularly if those individuals carry a genetic variant that predispose them to this. So let's talk a little bit about the youth, the adolescent, the young adults. We know that 70% of all mental health conditions arise by this age, because this is a critical time of both biologic and social change. The brains undergo maturation, the synapses undergo pruning in the prefrontal cortex, there's improved efficiency of information processing, neural connections between prefrontal cortex and other regions of the brain are strengthened. Now, you're going to hear a lot of great science today, and you already know about them. So this biological process is important. It's a time when the environment is also changing for these adolescents and young adults. Transition to independence, peer influence, finishing school, forming lifelong habits. Well, this is susceptible age. Surveys in United Kingdom found 38% of young people report that social media have a negative impact on how they feel about themselves, and exacerbated for girls, with 46% of girls stating that has a negative impact on their self-esteem. We know that children and young people are currently experiencing a mental health problem, are more than 3 times likely to have been bullied online. So these are really important issues. As we see the increasing incidence of mental health globally, we know this related to better detection, more awareness, reduction of stigma, but also increasing social factors. Now, take, for example, you can hear about this, what we face with right now with COVID-19 and other environmental disasters. It certainly has affected people's mental health and well-being. And it's created new barriers for people suffering from mental illness and substance use disorder. Many experts call this a second wave of mental illness, a second pandemic, if you will. During the COVID-19, we know that early studies show already 30% of US adults report stress, anxiety, sadness that was difficult to cope with by themselves. But if you look at time, it's getting worse. In March, 32%. Now, in July's data says even 53% feel they've been negatively impacted from their mental well-being. And we know, of course, social distancing, lockdown, creates isolation. and that's a factor. And for the elderly in particular, when already 43% of older adults feel isolated, this problem is getting worse. So, but COVID is not the only example. Katrina, other environmental disasters. During Hurricane Katrina, we saw high rates of acute stress, PTSD, depression, suicide, increase in interpersonal violence, domestic abuse, risky behavior, alcohol, and other substance abuse. And of course, the damage due to environmental disasters can limit the resources available for mental health care. So what are we doing about this? Well, today, we still have a lot of work to do. Despite the high burden of mental health, there are many discussions on priorities. Progress has been slow, and that's why your help is so important, and also the great work that you hear some of the other speakers are doing is important. We know we have a problem with access, but 1/3 to 1/2 or more people with serious mental health disease do not receive treatment. We know stigma is a problem, and that can deter patients from seeking treatment. It also influences the way the providers care for patients. We know our American healthcare system is highly fragmented, too specialized, not integrated. So someone with mental illness has to navigate a complex maze of different providers to get help. We also know that social factors are important, so-called social determinants of health. And yet, a medical social service are separate and not integrated. We know we don't have enough healthcare professionals who can attack this problem. Nearly 90 million Americans live in areas with a shortage of mental health professionals, and 2/3 of primary care physicians report difficulty referring patients for mental health care. So we need to do a lot more training, not only training specialists, but primary care physicians, healthcare providers. And so this way, they will be more sensitive and be more prepared to assist people with mental health problems. At the end of the day, I think the real issue is priorities and resources. If you look at globally, this is a big problem. The investment in mental health is pitiful. You know, if you look at global data, 33% of countries allocate less than 1% of the health budget to mental health. And even when they invest it, they put it into mental health hospitals, standalone institutions, separate from community. We do know that where we have to go is patient-centered, community-oriented care, integrated into routine care and social care platforms. And of course, health systems, being a previous CEO at Duke, don't always prioritize this. I'm afraid to say I tried really hard, but we need to change the way we look at things. And of course, there's inadequate research investment. But there has been hope and optimism because this problem is becoming recognized more and more and more in our country and everywhere else. In 2013, the WHO's Mental Health Action Plan was adopted with the highest level of political commitment from all 194 ministers of health in the World Health Assembly. So they have clear objectives, actions, targets for 8 years. In 2015, the Sustainable Development Goals recognized promotion of mental health, prevention of mental and substance use disorder. 2016, the World Bank endorsed mental health as a global development priority. And 2018, Lancet Commission says we need a reframing of mental health. So my point to you is, and you know this, we all need to change the way we look at mental health, the way we deliver care, and the way in which we use science and technology and new models of care to address this. I'm actually optimistic because I know there's a lot of excellent science going on to understand brain health and mental illness. I think we need to include a lot more social behavioral sciences. We know there's an effort to improve the care of people with mental illness. We do know a lot more needs to be done. Transform the whole field. Care must address the daily needs, not when they need to seek your help. A patient with illness. We have to work on prevention. We have to effectively utilize innovation, science, and technology. As we can talk a little bit more about this. And of course, we need a major leapfrog in science to understand the complexity of the brain biology and apply this new development, treatments, and therapies to improve the health of everyone, particularly in the area of mental health. Thank you for listening to my initial comments. I'm happy to turn back to Eric, and presumably he's going to ask me some tough questions.
Thank you very much, Victor. That was spectacular. I want to remind the audience to please ask questions in the Q&A function. I'll get the questioning rolling. Dr. Zhao, you mentioned the challenges that we have with access and barriers to mental health care. And I was wondering what you would suggest as president of the National Academy of Medicine of specific steps that we can take in this country to improve access to mental health care. You touched on it a bit, but I was hoping you could expand.
Sure. Well, at our National Academy, we convene experts. As you know, we discuss this issue. We write reports and we do policy, which Congress and administration frequently seek our advice, and that also many foundations and healthcare providers. So we have had reports. One of our most important reports is called Neurons to Neighborhood, linking the issue of brain development, mental well-being to, in fact, where you live and your early childhood and the importance of environment. We've looked at this issue, Eric, about delivery of care, and like many other experts in the area of healthcare, we've concluded that this has to be integrated in the fabric of day-to-day care. And of course, the place to start off with is in primary care, right? Primary care where people are sensitive, aware, can actually sense and detect early issues and being able to provide with the support before you even have to refer to, if you will, specialists. So one of the most effective ways is to do integrated team-based primary care. That team-based primary care with nurses, social workers, sensitive to this issue and trained in the area of mental health, be able to provide that kind of team-based approach, but actually with emphasis on wrap-around services, social work, case management, medication adherence, and others. Important to think about linking self-care to primary care. In other words, what you have to think is to normalize mental health care as routine in primary care and to integrate it into chronic disease management. So let me talk a little bit about what I'm saying. At the end of the day, people spend the time at home, in their community, at work. So you can't see care as episodic. You come to see me, I'm going to take care of you. So it's really important to integrate community-based organization, workplace, as One Mind is doing, and share activities between the clinic as from the community-based organizations. And of course, there are models in HIV treatment, for example, called the Ryan White model, which even integrates funding, which allows people to share the care of the patients. So that's one. The other thing that's really important to understand, of course, is that when people come to you, it's proposed that really should look at, make sure you understand the social backgrounds, social determinants. Some people call it trauma-informed care. That is, what's their individual, family, community level trauma, how they're vulnerable to the situation, and how you can intervene. Last point I want to make. I want to come back to the community issue. Because in US, we talk a lot about this, but in the rest of the world, where resources are even less, they have to be very innovative. And the innovation here includes examples in India, where there's organizations called Sangath, large NGO, where they utilize community workers and lay people to provide at least support services and, to support them when they're depressed, to be able to manage, even in schizophrenia, as a way to reach out to community before you have to go to a specialist. So if you bear with me, the other thing I do want to talk about is what's in the future. So one is changing the model of care. Second is science and innovation. This to me is the good news. If you look at where we are today with mobile devices, cell phone, iPhones, tablets, you name it, they are now used to monitor progress. And therefore, as I'll talk a little bit more, they're really useful in the future to very early detect and for people to intervene. There's internet-based support groups, and you already heard some of their online services. And of course, there are apps for treatment, including depression, anxiety, and addiction. So when you look at telemedicine, for example, I think COVID has shown it can be used effectively. And as many of you know, there's been 1,000% increase in the use of telehealth. But when you look at how telehealth is being used and data show that it works, when people have mental illness, the ability to connect through telehealth is very effective and important. So particularly in areas when people have difficulty to have access, remote areas, is extremely effective. During COVID, already there's a, shall we say, loosening, if you will, of the regulation restriction in the practice of telehealth and the reimbursement, both federal and state. And so I think that we don't want to go backwards. We want to use it a lot more for support of mental health. But also new technology, artificial intelligence. There are places out there where they use data sets to monitor, for example, voice recordings is not what you say, it's how you say it. So when you begin to use the algorithm and understand the normal behavior, any changes, you can begin to look at stress and perhaps early depression. And there are companies out there like Strong Mind, who's working with insurance companies to, in fact, connect with this and even cover the payment for this. So I think that AI, not only in the application of this, but eventually would be able to help people to self-navigate and shall we say, treat. So I think there's a lot of excitement on this area, and I am optimistic, Eric.
Fantastic, Victor, thank you. Brandon, go ahead.
Yeah, Victor, thanks for sharing your wisdom and knowledge with us today. We have questions pouring in from the audience. You're a popular guy, and people want to hear more about insights. I'd like to answer one of these questions right now, if you don't mind. Let's see, where is it? Here it is. A question from Colleen Buckley in the audience. Can you address the problem of mental health care providers, especially those in rural areas, getting paid for their work? This is a huge obstacle for our beloved private providers.
Well, I think Colleen's
and Victor, before you get started, let me just broaden that question a bit, because there's another audience question, not only highlighting rural areas, but at the opposite end of the spectrum, inner city areas where the challenges are also great but different. So how can we get around zip code determining the level and quality of care?
Well, if you in the zip code area, obviously we're talking about the particular issues of social determinants, which is so important. Understand the environment they live in. That's why I keep on emphasizing that it shouldn't be seen as episodic care. We have to really get into the environment, the community. On Colleen's question, this is the big challenge, isn't it? I think we do have to really change reimbursement system, payment system. My own feeling is we're moving in the right direction in the nation, particularly as we think about more integrated care. And certainly there's a lot more emphasis on integrated care the accountable care organizations, etc., the more you're interested in the outcomes, the more you're likely to spend money on prevention and early intervention, the more likely, therefore, be successful. So to the extent not only about payers changing things, but in those accountable care, you manage your own dollars. And if you're able to distribute and say, who am I going to pay first, second, I would definitely pay a lot more to frontline workers. But we do need a lot of policy change.
Absolutely. That's very true. And One Mind is working with other mental health organizations to advocate for policy change at the federal level. Another question from the audience, and thank you so much, Victor, for that.
Sure.
And another question from the audience. Anonymous attendee asked this question. How can psychiatry either collaborate with and or learn from other medical disciplines like cardiology, pulmonology, oncology, et cetera, to better understand the causes of mental illness and better personalized treatment?
Yeah, I think this is where research is so important. And, to get down, I'm a cardiologist. If I look at the last 50 years, there's 50% reduction in mortality. It's not just the drugs, it's not just devices. It's actually going to understand what are the predictors, what are the reasons. Framingham study, look at the risk factors, cholesterol, you name it, and begin to bring in the idea of attacking those fundamental factors led to it. I think a lot more research is needed. I think research both in the basic science, but also in translation, connecting social sciences to biologic sciences and medical sciences, and bringing together all different sciences to look at how to make a difference, what we call convergence, if you will. And then the implementation piece. We don't do enough implementation science, which is now that how do you improve the models of care we just talked about, and what's the evidence of how to approach this?
That's very true, and that's why One Mind is doing implementation science support through our Aspire program. So thanks for highlighting that. Another question, we have a couple of questions about relating to peer support. Let me just read this one question from Obi Felton in the audience, and then that dovetails with that from another audience attendee. A few questions related to access, Obi asks. How can we grow the pool of mental health providers faster? For example, training more therapists like IAPT in the UK, but given the evidence for integrated care being highly effective, why is it not implemented more? And then the third part of the question is, what do you think about peer counselors like the Friendship Bench? Would that be a lot faster to deploy than brain health licensed therapists?
Oh, absolutely. I think for the last one, I'm not an expert in this, but I can tell you is what I said earlier. If you look at what's going on in India, these people really are peer counselors, but people who are actually there connected and being available to everyone. I think that's so much more important than having the super specialists. Of course, we need them, right? So I think how to move things faster has to be, number one, changing our education paradigm. But by that, I don't mean, make sure that doctors understand this, but I think all health workers, community workers, at least need to know the fundamentals of mental health and well-being. But secondly is changing the whole payment system. There's no question in our country, what's happening is the payment warps the incentives, and consequently there are more specialists and much fewer people in the community and primary care, integrated care. So I support accountable care, the ACA, what we call Obamacare, because we're moving towards alternate payment models where more and more you're looking at outcomes and looking at, in fact, early care in terms of ambulatory and less specialty care.
Thanks, Victor. That's wonderful to hear. Eric, you had a question for Victor, I believe?
Yes, we only have a few minutes left, Victor, but I was hoping you could end by telling us about HBGI.
Yeah.
You talked about the need to leapfrog for a dramatic change in the way we address mental health globally. Please tell us about HBGI.
Well, so I think the issue here, as I said, is do we have enough attention? Do we have enough investment? And we need to leapfrog the way we do things. So I've been very fortunate to be connected to Gary Staglin. He's the one who's recruited me to say, we have this bold idea, you want to help. And when I listened to this bold idea, I said, of course, it's the best idea I've ever heard in this field. The idea of creating enough resources globally to address the issue of mental health through research and implementation. $10 billion, a financing mechanism. That's a lot of money. I think we need even more. But 10 billion in there of using a different financing mechanism so that there's sufficient resources to spend over 10 years to change the way we do things. So quickly, what are they? One, of course, we recognize, as been said by Brent and others, that research has to be looking at outcomes and how to implement. We do know that a lot of ways which we know how to implement, but they're not, in fact, done in low middle-income countries. So implementation science is really important, can change the burden. Translation and discovery science. When you look at the research which is being done, and there's tremendous research, good basic research, we need to bring it to patient research. That is being able to look at what's happening in their brains, what's happening in the population, and how can we actually look at understanding population around the world, having new cohorts for studying, and the material to study. So this mechanism is bold. The idea is to raise 10 billion using a number of different mechanisms, such as philanthropy, really important, such as impact investment, such as creating a bond, where people can invest over time. The California CERM or stem cell bond, 3 billion, is a good example. And over time, the return investment is over $11 billion in California alone in economy, but also improving health and management, and going to sovereign funds and going to corporations. So that's what we're working on. We've got some of the best minds in research looking at what needs to be done to leapfrog research, best mind looking at measuring the success, best mind in looking at how to raise the money, and importantly, how to create an independent organization that's multinational and as a group like the Global Fund to make this happen. I'm truly excited about this. I think this is a bold initiative that can truly change the field.
Excellent. That sounds like such an exciting initiative. We have several other audience questions, but in the interest of time, we're going to move on to other speakers, but we'll return to you, Victor, at the end of the session when we have a more general question period from the audience. So our next speaker is Michelle Krask, who has been a longtime member of the One Mind family. Michelle is a clinical psychologist and distinguished professor at UCLA. Michelle holds the Miller Endowed Chair in Psychology, is director of the Anxiety and Depression Research Center, and is associate director of the Staglin Family Music Center for Behavioral and Brain Health at UCLA. Michelle, thank you so much for joining us.
Thank you so much for inviting me to participate in this very, very important set of talks. And as has already been well described, the COVID-19 pandemic is a firestorm for mental health. So it's no wonder that rates of depression, anxiety are increasing. Some reports are that the rates have increased 3 to 4-fold. And of course, the exact rates due to COVID-19 may not be fully understood for years to come. We were already facing a mental health crisis before COVID-19, with rates of depression, anxiety, suicidality increasing globally, especially among the younger age groups. And of course, the pandemic has just exacerbated that crisis. We face enormous challenges, but what I want to emphasize in my brief talk today is that we also have very clear pathways to meeting those challenges and reason for hope. Now, the first challenge that was already mentioned is stigma and prejudice around mental health. It's obviously the case that we've come a long way. Nowadays, we're much more accepting, especially the younger generation, but nonetheless, fears of negative repercussions persist, and fears not only add to the pain of the person who's suffering, but also deter them from seeking help. So we need to really work on this issue. And of course, there are groups leading the way, including the enormously important work of One Mind, and the various celebrities and athletes who are speaking out and encouraging others to do so. I've been inspired by organisations, particularly my home country, Australia National Football Association, believe it or not, who now publicly declare the need for days off for mental health as much as for physical health recovery. But aside from public engagement and policy making, there's another untapped pathway, and that is the science that already exists around the topic of bias and prejudice more broadly. We need to bring that science to the topic of prejudice around mental health. And at UCLA, we have taken on a grand challenge for reducing the burden of depression by 50% by the year 2050. And it's called the UCLA Depression Grand Challenge. And one of the major pillars of our challenge is the topic of stigma around mental health. And to that end, we have brought together a team of scientists and scholars from many different disciplines, all tackling the problem of mental health stigma and finding ways forward. Now, the second challenge is getting help. The bad news is that less than a half of individuals with mental health problems receive any kind of help, and that's in the United States. In California, it's more like 37%. And of course, the pandemic is stretching our mental health resources even thinner. We have made great strides over the last few decades in terms of evidence-based treatments. So the good news is that there are treatments that work. And even better news is that we're continuing to develop more laser-targeted, more personalized, and therefore more effective treatments. And that is another major pillar of the UCLA Depression Grand Challenge. Here, we are studying depression from all angles, from genes and cells to brain to behavior, so that we can better understand the causes of depression, the maintaining factors of depression, and then use that information to develop treatments that are more honed and precise to the needs of each person. As one example, we've developed a new treatment for symptoms of anhedonia, or loss of interest or pleasure in usual activities, that's really been difficult, if not impossible, to treat up until now. And we're using virtual reality as a tool to facilitate that new treatment for anhedonia. And we, the Depression Grand Challenge team, have partnered with Apple to develop behavioral tracking tools from smartphones and wearable devices so that we can track behaviors like sleep and activity. And we believe that these tracking tools will help elucidate how depression differs between people and how it changes over time within the same person. And with that, we'll then be able to enable greater precision in preventing self-harm, in deciding when is treatment most critical, and even which treatment is likely to be most effective. In other words, these behavioral tracking tools offer the promise of even more personalization and thereby more effective treatments. But the challenge, back to the challenge, how do we make these evidence-based approaches to treatment and tracking more widely available? As I said, less than one half receive any kind of treatment, let alone state-of-the-art treatments. And there will never, ever be enough clinicians to meet the need. So we need a new methodology, a new model to meet the challenge of the mental health gap. New technologies provide the answer. Using smartphones and the internet, we can detect and actually deliver treatment to depression and related conditions on a scale that has not been previously imaginable. We at the Depression Grand Challenge have developed a system of care for screening, tracking, and treating depression and anxiety called STAND that relies upon these technologies. It begins by a symptom screening that can be conducted anywhere at any time on any internet-connected device. And that screening gives immediate, within minutes, feedback and routes the individual to the appropriate level of care. So for those with none to mild symptoms, we offer cognitive behavioral therapy online for prevention purposes, and that is self-guided. For those who are mild to moderately depressed or up to severely anxious, we provide cognitive behavioral therapy programs that are online but supported by coaches who are trained and certified and provide guidance by remote video chat. And for severely depressed or suicidal individuals, we triage them to clinician-delivered care, nowadays by telehealth. And so in this model, we reserve the trained clinicians for those who have the most acute needs, thereby making it a scalable model. But we do more, because we continuously track symptoms. Once people enter the STAND system of care, we're tracking, and that enables us to adapt the treatment to match their needs as they evolve over time. So, for example, we rapidly switch people to a higher level of care if their symptoms worsen in order to prevent full relapse, or we switch people to a lower level of care to maintain therapeutic gains. And then on top of all of that, the continuous tracking enables us to respond immediately 24/7 to suicide alerts. Now, this fully integrated and adaptive system of care was developed to be transportable to any setting, to educational settings, to health settings, to workplaces. And we have successfully implemented this system of care at the UCLA campus for students, and we're now preparing to implement it in the UCLA health system. But what I want to finish with is talking about our latest development, where we are now implementing the STAND system of care in community colleges, starting with East Los Angeles College. Why? Because community college students face daunting challenges. Their rates of mental health are much higher than other four-year programs, for example. One estimate saying 50% of community college students are suffering a mental health problem. And that intersects with enormous life challenges. Of those with mental health problems in community colleges, 1 in 4 are homeless. 1 in 4. And over 2/3 struggle with housing and food security. And yet, by far the majority don't have access to any mental health resources. So with demonstrated success of our STAND program at East Los Angeles College, our vision is for the STAND program to become available to all community colleges in California and even elsewhere. Remember, for many community college students, attending college is their ticket to economic advancement. And for that possibility to be blocked by untreated mental health problems is simply a tragedy. So we aim to make mental health resources through STAND available to all community college students. And I'll end with that. Thank you.
Thank you, Michelle. By some measures, depression and anxiety are the #1 cause of disability worldwide, and your efforts to better treat them are outstanding. I wanted to ask a related question. What can we do in the area of prevention to reduce the onset and incidence of these conditions?
I think prevention is absolutely critical. You know, in many ways, once mental health problems emerge, they have a scarring impact. And what I mean by that is they tend to create greater risk for future episodes. And of course, there's the suffering that comes with each of those. So prevention is critical. There are programs for youth, parenting programs, school-based programs that have been shown to be effective. They are still costly and not easily implementable. And what we have done is taken a version of our STAND program to treat at-risk kids 12 to 16 years of age using a mindfulness-based intervention, again with certified and trained coaches who provide help by video remotely. And we're doing that in Imperial Valley, where the rates of anxiety and depression are higher. the rates of poverty are very high, and the access to mental health resources is almost nil. And we believe that, again, by demonstrating success in these kind of settings, these online programs with coaching could become a real avenue for preventing the onset of depression and anxiety as these kids grow up.
Michelle, that's great to hear you doing that work in Imperial Valley to help people who have lack of access to mental health care, especially young people, where the most help can be, the help can be most effective throughout the course of people's lives. You were talking earlier about lack of access for so many people to mental health care. We have a question from the audience. Wes and Gail Lynn Ayers asked this question. It's actually been voted up twice by two others, so it's a lot of interest in this question. She says, I was reading an article in The Economist about COVID-19 and mental health that mentions how hundreds of grandmothers in Zimbabwe were trained as lay counselors in order to provide talk therapy within the community who do not have access to treatment. How might seniors with a lifetime of experience help to provide love and support in this manner in our country?
That's a great question, and it ties broadly to the issue of paraprofessionals that has been brought up before. And you can see in our STAND system of care, we rely on paraprofessionals to do coaching, and we train coaches to fit the needs of the setting in which we are working. So in community colleges, our coaches are other students, so we actually train the community college students to be the coaches. When we go into health settings, we work with different kinds of coaches, but older age groups and providing support is yet another extremely interesting avenue to follow. And I think the critical issue here is adequate training and developing not just models of supervision so that the coaching and the paraprofessional support is done with high fidelity, but models of coaching that are in themselves scalable. So we need some systems, and we're playing around with how to do that ourselves, that are more automated, that provide ongoing supervision and feedback to keep the paraprofessionals at their highest level of quality of care. But it's just a fantastic idea.
That's exciting, Michelle. Great to hear about the technology augmentation for extending the ability of paraprofessionals and professionals to reach more people in need. Thank you, Wes and Galen, for your question. That's an excellent question. Another question in the audience from Emilia Zmergala. Can the STAND program be adjusted and implemented in public school K-12 setting as well? Another question in the audience, similar, can it be available in high schools?
Can the STAND system of care be implemented in high schools, I think is what you're asking, right? Sorry, it was a bit difficult for me to hear. But theoretically, yes. When we go into community colleges, the biggest issue is, as I described, our highest level of care is clinicians. So we still believe that while digital mental health is extremely valuable, it is simply not enough for somebody who's suffering with extreme depression or is suicidal. And so you always need to have that clinical level of care available and reserved for those with the greatest need. So STAND can go into any system as long as there is a support mechanism to provide the clinical level of care. For community colleges, we're working with the Los Angeles County Department of Mental Health. They are the group that are providing the level of care that is clinical in nature. And so I think as long as there's that option, yes, this program would suit in high schools.
Michelle, I have one more question for you before we move on into the program. You mentioned virtual reality as a treatment for anhedonia. That sounds very sci-fi. Can you say a bit more about that, please?
Yes, it's sci-fi indeed. You know, when we work with patients who have anhedonia, the nature of the problem is that it's very difficult to be motivated to want to engage in rewarding activities. But we know that if you can engage in those kind of activities, it can be beneficial. But simply asking somebody to do that is a struggle, especially if they've become chronically isolated and there's very little available to them that could be rewarding. What virtual reality does is it brings the positive experience to the person. So it becomes this excellent tool for providing an experience and then working around that to teach what we teach in our treatment, which is attention training, to how to attend to the most positive features, memory training, how to encode and retrieve that parts of the experience that were most positive and practice that over and over again in order to facilitate, if you like, the brain muscle for positivity.
Excellent. Thank you very much, Michelle. We're now going to move on to the next portion of our scientific program. Our next two speakers are recipients of One Mind's prestigious Rising Star Awards, which are given to early stage investigators with great promise. I want to acknowledge members of One Mind Scientific Advisory Board who select the award winners this year from close to 100 very deserving applications. First up is Dr. Kevin Bayer, who is an assistant professor of physiology and biophysics and a member of the Center for Learning and Memory at the University of California, Irvine. Kevin received the One Mind Janssen Rising Star Award named in memory of a dear colleague of ours, Dr. Jeffrey Nye, who has been a supporter of this program at Janssen. Kevin, thank you for joining us.
Awesome. Thanks, Eric. So I'm just going to give you a real quick introduction to the research going on in my lab. So our goal is to identify the biological factors that are predisposing individuals to developing major depressive disorder. And so while treating depression is a major goal, it can be very difficult largely because depression is largely heterogeneous. So there are a variety of sort of common behavioral features like hopelessness or sadness that present it in a lot of individuals with depression. There's also a lot of heterogeneity to it. So some patients with depression will sleep more than normal, some will sleep less. Some patients will eat more than normal, and some will eat less. And yet clinically, these are all classified under the broad umbrella of depression. And so while we know, depression is a very real phenomenon that has very real societal and personal consequences, it's very difficult from a clinical standpoint to treat because we're really lumping a lot of potentially very different things under one category. And so an approach that has been raised earlier by Michelle and others is this sort of idea of personalized therapeutics and the potential for developing approaches for patients with mental illness that can be tailored to the particular symptomatology that those individuals have. And so one of the major challenges in treating depression is that the state of the art is really to prescribe these pharmacologic agents that we know have some efficacy in some patient populations, but there's really no one-size-fits-all approach. That really the general treatment strategy is to try different antidepressants, the serotonin-specific reuptake inhibitors most prominently, and essentially cycle them until we find the one that works. And that, of course, has the problem that there's a lot of patients that don't respond well to these therapeutics, and we really don't know how these really even work on a molecular circuit or on a behavioral level. And so without the sort of understanding of the basic mechanisms of why patients are developing depression, it's very hard to develop these sort of personalized therapeutics that would enable us to treat patients with higher efficacy and fewer side effects. And so our goal then is to understand more about the very basic mechanisms of how these things work. And so in our lab, we're using rodent models because there are a number of things one can't do in human populations. For example, it becomes difficult to establish cause and effect relationships in the brain. And so in the rodent models, we're able to test very specific hypotheses about the roles that specific molecules or cell populations play in the depressive behaviors that we're interested in. Of course, the issue is when one uses a rodent model is what exactly is rodent depression? Unlike humans, where we're able to communicate how we feel, and certainly that's one of the major ways that depression is communicated, rodents can't really do much of the same. And so we're reliant on interpreting their behaviors. But in effect, this might be a sort of blessing in disguise because we have to provide a laser focus into the behaviors that the rodents are showing, and we can therefore start to understand these very basic mechanisms of the behaviors, the symptomatology that is associated with depression. And so rodents, like humans, respond to chronic stressors in ways that are not always adaptive, that can lead to symptoms associated with depression. And so using these rodent models of chronic stress, my lab is proposing to investigate the biological sources of depression vulnerability. And so there is some discussion and comments about the identification of biomarkers for depression, trying to identify individuals who are vulnerable to developing depression before they do so. And so the goal of our lab is to actually identify in the brain what these biomarkers may be early on before depression develops. And then once we've done so, because we're using a model that has very high resolution, we can then dive more deeply into developing potential pharmacological interventions for treating these patients. And then, of course, these can be used potentially down the line in combination with the sorts of behavioral tracking tools that Michelle was talking about to target these for particular patients suffering from mental illness to push forward this idea of personalized therapeutics.
Thank you, Kevin. Let me follow up with a question. Michelle talked about the importance of anhedonia as a very difficult symptom of depression syndromes in humans. You talked about trying to study depression-like phenomena in a mouse or a rat, which can be challenging, as you acknowledged. How can you tell if a mouse or rat gets depressed? But anhedonia is actually a type of symptom that perhaps we can study quite well in a mouse or rat. Can you say a little bit more? What are the kinds of things that we would do to see whether chronic stress in your hands would make a mouse or rat experience an anhedonia-like phenomenon?
That's right. So there are a number of behaviors that one could study in the rodent model to look at anhedonia. For example, we propose to use this social defeat stress model that your lab has used quite prominently. And one of the behavioral features that some of these animals develop is this anhedonia phenotype, which in rodents is often expressed by what's called a sucrose preference. And so we can identify animals that essentially don't feel the same reward from drinking sugar water that normal animals do. And there are also a variety of other similar sorts of tests that can identify animals as undergoing anhedonia or not. And so our goal is to link using the mouse model that we're using, essentially how the animal responds on an activity level in the brain to whether they develop this anhedonia phenotype or not.
Excellent. And I think it's important to emphasize that a mouse or rat, just like a human, enjoys doing things in its environment, whether it's eating Reese's Pieces or drinking sugar water or having sex or having social interaction. And we can measure the degree to which a rodent participates in those activities that are naturally rewarding for it, just the way we as clinicians evaluate how patients with depression are able to enjoy themselves through their own rewarding activities. Thank you very much. One other question before we move on to the next Rising Star Award recipient. One of the features of your proposal that the review committee commended was its use of an unbiased approach. And I was wondering if you could tell us what that means and why it's so important.
Yeah, so one of the major limiting factors of our investigation into the sources of mental illness is that inherently the approaches that we're using are biased by the results that come before them. And so this makes sense because we're building on the discoveries of others, but it also funnels us into very specific avenues that we may be missing the proverbial forest through the trees. And so my approach that we're taking in the lab, it is using some of the foundations that others have built, but we aim to cast a much broader net to come in with not a specific idea of how the brain is working or what regions, cell populations, molecules might matter, but to essentially listen to what the mouse is doing, look at what our readouts are telling us, and use the data to then select the major brain regions, major cell types that are driving the behaviors of interest. So hopefully we can discover new things and basically accelerate progress towards development of new therapeutics.
Fantastic. Thank you very much, Kevin. We're going to move on and we'll get back to you with additional questions later on during the program. But it's now a pleasure for me to introduce our last formal speaker of the day, Dr. Greg Fonzo. Greg is an assistant professor of psychiatry at the New Dell Medical School at the University of Texas at Austin. Greg received the One Mind Bozuki Brain Research Funding Rising Star Award, which is focused on bipolar disorder. Bipolar disorder is a syndrome about which we still know relatively little, which is relatively common and which has not received nearly the investment that it warrants. Greg, thank you for joining us. Congratulations on the award, and please tell us about your Rising Star Award proposal.
Thank you, Eric. It's a pleasure to be here today. Thank you, Brandon, and I'm very excited to tell you a little bit about the research that's been generously funded by the One Mind Rising Star Award. Broadly speaking, my research is focused on developing new and effective neuroscience-based treatments for affective disorders, including bipolar, which are those mental disorders that are predominantly characterized by dysregulated mood and emotions. One way to do this is to try and directly target the brain regions that show abnormal functioning in these conditions. So common affective disorders like bipolar disorder, depression, anxiety, and even post-traumatic stress disorder are consistently characterized by elevated activity of neural structures located deep within the brain, which are involved in generating emotional responses. Now, the most important of these structures is called the amygdala. Now, the frontal lobes of the brain are responsible for regulating these deep brain emotional responses. So as an analogy, these deep brain structures, like the amygdala, are like the accelerator on the emotional car, while the frontal lobes are more like the brakes. Now, in states of dysregulated mood, this frontal control of deep brain structures involved in emotion is deficient. In other words, the brakes become worn out and don't work as they should, which basically doesn't allow the car to slow down because the accelerator is too sensitive when it's pushed. Typical psychiatric treatments, such as antidepressants, mood stabilizers, and psychotherapy, only indirectly target these brain structures, and they're not effective for a substantial number of individuals. This has led to the development of brain modulation as a treatment tool in psychiatry, in which electrical or magnetic forces are used to stimulate or inhibit specific sites in the brain in order to more directly augment brain function. However, these current methods are limited. They can only reach surface areas of the brain, for the most part, in other words, those that are close to the skull. Therefore, only the frontal lobes can have their function augmented by these technologies. So in terms of the car analogy, we can only improve the brakes with these tools, but we aren't able to reduce the oversensitivity of the accelerator pedal. However, a new and exciting area of development is the use of high-frequency sound waves, known as ultrasound, to modulate brain function. Ultrasound has key advantages over other brain modulation technologies. Most importantly, it can reach these deep brain structures like the amygdala. It can also be more easily combined with neuroimaging tools like functional magnetic resonance imaging, which can be used to observe brain function as it occurs, and which can allow us to verify firsthand that we are hitting the right target for the individual. Lastly, it can be delivered to a wider segment of the population, since it doesn't interfere with any electrical implants that might be present, like pacemakers or potentially metal in the skull. So the goal of my project that's going to be funded with this Rising Star Award is to use ultrasound waves to inhibit the function of the amygdala in individuals with bipolar and other affective disorders, which would be a brand new method of correcting this emotional imbalance in the brain. So instead of improving the brakes, we're going to try and use ultrasound to reduce the sensitivity of the accelerator pedal, to go back to our car analogy. And additionally, we're going to combine this ultrasound technique with neuroimaging. So that way we can look in near real time how the ultrasound waves might change the function of the brain target and how this might occur differently in those with an affective disorder. This will allow us to more effectively target the technology to where it needs to reach in the brain in order to have a therapeutic effect and to observe how the rest of the brain responds when the amygdala is turned down. So people that participate in the study will undergo this ultrasound procedure once a day for several weeks to examine whether this improves mental health symptoms. And the hope is that repeatedly desensitizing the accelerator pedal with this ultrasound will correct the imbalance in the brain that leads to mental health symptoms of mood dysregulation, like those seen in bipolar disorder, depression, and anxiety. And if we're successful, this could usher in a brand new treatment modality for psychiatry that's informed by brain circuits, directly targets a dysfunctional brain process, and can be more flexibly applied to a wider range of individuals. So thank you for giving me the opportunity to tell you a little bit about that.
Thanks, Greg. Let me follow up quickly with 2 quick questions to get some clarifying information. First, the amygdala. Can you show us on your head roughly where the amygdala is?
I could, but I wouldn't survive the procedure, unfortunately. It's basically, it's located deep within the temporal lobe, which is the lobe on the side of the brain towards the center of the head.
How big is it in a human brain?
It's about probably 1 to 2 centimeters in diameter.
So maybe the size
small.
of a marble, perhaps, on the side of the brain?
Yeah, probably a little bit larger than that, but yeah, that's about right.
And most of us, when we hear the word ultrasound, we think of going to the doctor and having an ultrasound test for our abdomen or heart or another organ. How are you using ultrasound for brain?
Yeah, it's a good question. So ultrasound has been classically used as a diagnostic tool in order to be able to look at what's going on, for example, in the brain or other parts of the body. In this case, we're using a multi-transducer array, which allows us to basically use multiple sources of sound waves that will converge on a specific focus. And the idea is that then we're depositing the ultrasound energy into a specific area that we're targeting.
Excellent. So we have lots of time for questions to go back to all of our speakers. I want to encourage you all again to please ask additional questions in the Q&A function on Zoom. Before doing that, I also want to highlight that your support is tremendously needed to empower One Mind's efforts to promote brain health, not only in the country, but around the world. Please help us by texting brain health, one word, all capitals, to 44321. And we'll repeat that message during the course of this question period. Let me now open up the program to more broadly to questions. And we received a number of questions from the audience focused on personalized medicine or precision medicine, as we've heard about it. I was hoping several of our speakers could say more about this. Victor, you raised it in your talk, and I was wondering if we could start with you, please. Can you tell us what is precision medicine and how does it promise to transform psychiatry? And you're muted.
Yeah.
If you could
Yes,
unmute yourself, please. Yeah.
Yeah, I think precision medicine actually is a term coined by the National Academies. In one of our reports, really talks about the ability to utilize information to predict, to be more precise the choice of treatment and cater to the individual. So many people confuse precision medicine or make it simplified as genomic medicine. That's not the case. It's actually taking all information, whether it's genomics or other omics, and electronic health record, and all the biosensors and all the big data, and using data analytics to actually come up with the algorithms that can find what information will be best in predicting your chance of disease and your response to therapy. That's what it is. So you can imagine that I already talked about the fact that there's a lot of vulnerabilities of individual to mental stresses, mental disorder. Biomarkers now they can be measured fairly easily using many different ways to collect the information. Certainly for those people who have, exhibited illnesses, there's a lot of other records, testing, you name it, electronic health record, and others. And importantly, the use of now of biomarkers, including genomics and other biomarkers, all come together to help you understand what is going to predict much better response to therapy. And for the few diseases where there's clear genetic variance, of course, the use of those testing, genomic testing, can be very useful as well.
Excellent. And Michelle, let me turn to you because you also highlighted personalized or precision approaches. We often use the words anxiety and depression as if they're describing a single entity, yet we know that both of these syndromes can describe many dozens of different disease states. Would you comment on that more, please?
Yes, definitely. Yes, it's true. Anxiety and depression do have a lot in common, but they also have a lot of differences. And even within anxiety and within depression, there are heterogeneous forms. So, for example, in anxiety, there is, the experience of a panic attack versus the worry and anticipation of future events versus recovering from traumatic experiences. In depression, we already talked about anhedonia, anhedonic depression versus depression without anhedonia, irritable depression. So there are many different forms. And when I think of personalized, my own choices, I don't say precision because I don't think we're at the level yet of precision, but personalized approaches. Just as Victor was talking about, what we are doing is we're collecting a whole array of data across biological markers, neurocognitive markers, behavioral markers, early life adversity, ongoing life stress, support, previous psychiatric history, preference for treatment, all of these kinds of things to then generate what we call data engines for predictive algorithms that could help us select which treatment would work best for whom. I think it's doable. It's just going to take a lot of data collection, and it would be great if there were many different people working together on this problem so we could quickly add up to the pool of data.
Thank you. An analogy to general medicine might be that if a person has pneumonia, through several diagnostic tests, doctors figure out exactly what type of pneumonia they have, which specifies the type of antibiotic treatment that they most need.
That's
and the
right.
idea would be to do the exact same thing for depression, anxiety, and other mental disorders.
That's right. And exactly. And, just to make it even cleaner, so even in the realm of psychological treatments for anxiety, if somebody's experiencing panic attacks, it's a very different approach than if they're experiencing worry, excessive worry, as in generalized anxiety about the future. But we need, rather than relying on diagnostics, it would be helpful to have more precise measurement of how to guide those treatment selections.
Thank you, Michelle. Brandon, I think you had the next question.
Yeah, thanks, Eric. We had several questions from the audience. A couple of these are addressed, looks like they're to Dr. Greg Fonzo. First question from Jan Bazuki. Looks like people would be interested in, if people are interested in participating in your study, can you say something about the recruiting process for your study?
Sure. So the recruitment process is going to be fairly broad. So we're going to open it up and look at people that have a general level of negative affect. So having a lot of, for example, mood dysregulation, depression, and that should capture quite a large segment of the affective disorder population, including bipolar, depression, anxiety disorders, and then we're going to basically quantify what sorts of diagnoses they meet criteria for. But the idea is we really want to look at this as a transdiagnostic mechanism. And the idea is that the amygdala, specifically, we know is a brain region that has been classically implicated in the pathophysiology of many of these disorders. And so the hope is that by targeting it with this technology, that we might be able to develop a sort of transdiagnostic approach to improving elements of negative emotion that we would see across these conditions.
That's great. So you'd help a lot of different types of people with different types of illnesses with that focused primarily on bipolar, but also other illnesses as well. That's fantastic. And then another question for you. This is related to the earlier question about personalized medicine. Let's see. The question was, you are planning to use the ultrasound work not only for treatment, but potentially also for understanding what other treatments might help people with conditions like bipolar or other mood disorders or anxiety disorders. How would that work? Like, how would you use ultrasound as an assessment tool?
Yeah, it's an excellent question. So the great thing about this ultrasound technology is that we can combine it pretty easily with tools that allow us to measure the brain in vivo. And I mentioned one of them, which is functional magnetic resonance imaging, which will give us a nice picture of how the brain responds. And so we can use ultrasound as a probe, essentially, of the brain. And the idea might be that we might target a specific area, turn it on, stimulate that area, and then examine what the downstream effect might be using the imaging readout. And then in that process, we can actually target various areas that we might think are mechanistically implicated in a particular treatment. And so, for example, if we think the amygdala response is important to predicting antidepressant treatment response or response to mood stabilizers, we might be able to sort of tickle it with the ultrasound and then get an idea of how it responds to that, which might actually be used as a useful prediction tool later on.
That's fascinating. Fascinating. Another question related to that. Can concussions affect functioning or sensitivity of the amygdala and thus trigger mood disorders? That question is from Sarah Cheesemore. Thank you so much, Sarah.
Yeah, that's a very timely question, especially given the recent heavy focus on traumatic brain injury. And I think the answer is yes. I will say that I'm not an expert in this particular area, but we do know that TBI can have widespread effects on the brain. And my understanding is that it can trigger things like depression or other forms of mood disorder. And there's a high degree of overlap in the way that those things manifest. Whether it impacts the amygdala specifically in order to trigger that is a very precise question that I would love to find the answer to. But my sense is that it is possible, but I don't know for sure.
Okay, that's interesting to know. This question is related. This is a question for Kevin. Kevin, does your work also explore activity in the amygdala and related circuits? For
yeah, the amygdala is certainly part of the unbiased approach we're taking, and it's certainly been linked to a variety of mental illnesses. I mean, certainly it's influencing, inspiring Greg's work. I mean, as Eric had asked before, we're not going to necessarily focus on it, but there are a lot of other structures centered around the amygdala that certainly are well known to influence a lot of various behaviors that we're looking at.
Kevin, your work refers to brain circuits. Can you tell us what that means? I think of a circuit being part of an electrical device.
Yeah, so there's been a major increase in neural circuit exploration, so-called neural circuits, in the last decade or so. It's been enabled by a variety of new methodological developments. Some of you may be familiar with things such as optogenetics that have allowed us to examine with very high precision how influencing the behavior of certain cells in the brain can influence other cells and also behavioral outcomes. And so when we talk about neural circuits, we're essentially looking at the connections between different cell populations in the brain and how different regions work in concert to orchestrate particular behavioral outcomes. And so there's been a major, increase in our understanding of how, not just targeted cells and brain regions perform, but how neural networks or multiple brain regions in combination perform together to influence behavior.
Right. So a single human brain, for example, contains maybe 100 billion nerve cells, each nerve cell forming perhaps thousands of connections with other nerve cells, which communicate with one another through electricity and then chemistry. And so when you talk about neural circuits, you're talking about all of those complex interactions, really more complicated than the world's most complicated computer.
That's right. And that makes it very hard to understand what the role of particular cells, or, as you say, circuits, multiple cells together, what role they're playing, because there is this very intricate connectivity, although despite its complexity, has a lot of specificity. And so the sort of approaches we're taking are designed to sort of look at these so-called microcircuits, so very well-specified connections, and how that circuit is influencing other behaviors.
Wow, that's amazing. I got a couple more questions from the audience. These are related to each other. A question from Karen Vicari and a related one from Stephanie Evans. Thank you, Karen and Stephanie, for your interesting questions. When we talk about digital, this is mainly for Michelle or potentially Victor. When we talk about digital and online mental health services, often the individuals most at risk do not have access to devices and/or internet. How can we work to ensure access for all people to digital services?
I would say this is a big issue of health equity. We recognize that everywhere when we're getting more into telehealth and others, people have to have access to it. And this is a big issue. If you look at in the area of COVID and the effect on education, and many students are trying to do online education, we clearly see that we are exacerbating, or at least we are unmasking, if you will, many of the equity issues. There are many efforts in trying to make this more, first of all, computers more available, hotspots to enable to be connected. But I think fundamentally, as we move this technology forward, we have to really be cognizant of the issue that you just talked about, which is the issue of equity.
And I totally concur. For example, in our work with community colleges, not all of the students have access to internet-connected devices, and so we have to provide them with devices. When we go to Imperial Valley, we're putting everything onto iPads and providing the iPads. We're also doing work in Uganda and South Africa, and again, a lot of people have cell phones, but not necessarily the phones that would be needed for the kind of work that we do, and it's just a huge disparity issue.
We've been talking today about a range of treatments for depression, from digital health and virtual reality to medications, which are standard, as well psychotherapies, which are standard. Greg talked about ultrasound. What about even more extensive treatments, such as electroconvulsive seizure therapy, or deep brain stimulation, or direct current stimulation? Would someone take these on? These were sometimes referred to as somatic therapies, which can also be very effective, particularly in people with the most severe forms of depression. Would one of our panelists like to take that on? Greg, go ahead.
I'm happy to take that on.
Sure.
Yeah, so yeah, these are all, some of these are sort of very old forms of treatment, like ECT, for example, or electroconvulsive therapy, which is actually highly effective. It does, unfortunately, come with a lot of usually side effects, like memory loss and that sort of thing. And so it's typically only utilized as a last resort, a treatment approach. But it is something that definitely has been shown to work quite well. And what we do in that is we deliver electricity to the brain such that we cause a seizure. And that's repeated multiple times over the course of several days in order to affect a change in the person's mental functioning and mood state. There are others that you mentioned as well that use electrical or magnetic stimulation approaches. So there's the direct current stimulation, or it's known as transcranial direct current stimulation, which is a much milder form of delivering electricity to the brain compared to ECT. And it does, it lacks some sort of spatial specificity, I guess we could say. It's a little non-generalized in the areas that it hits, but that is another approach that is being widely researched at the current time. And then there's other forms of treatment as well, like transcranial magnetic stimulation, which is currently an FDA-approved form of treatment for treatment-resistant depression.
Yeah, Eric, I was the one who asked the question.
Go ahead, Victor.
Because I was dying to hear from, because we've been looking at these issues, particularly the direct current transcranial stimulation. And of course, the data is kind of mixed. It's not as good as it should be. And it's approved in Australia, in Singapore, but not in this country. And so it raises a lot of issues. I really think this is so important because technology is going to move forward, and some will work and some may not. And then the whole issue of, shall we say, direct-to-consumer of this technology to even do yourself. So we have actually looked at the whole neurotechnology at the Academy in some detail about where it is and what is Could be, and I think I would say the potential is there, and if it works, it'll be great. And I think it's a real pathway, again, as I said, about innovation, but there's still a lot of work to be done. Then you can imagine the interface between brain and computer and AI. So I'm only thinking in the future, not today, about how, in fact, these technologies may be useful in the future, and importantly, how would they be regulated and overseen to prevent the misuse, such as enhancement of performance, and you name it.
Absolutely. And you know, I think one of the cardinal features of new treatments, as we all know, include safety and efficacy. The treatments have to work and they have to be safe. And so that people should follow the science in terms of what the data tell us in terms of treatments that meet those criteria. And this is where personalized precision medicine is so important, because one of the reasons why the data may be mixed is because the treatments are not being applied to precisely the subset of people who most need that particular intervention. Brandon, go ahead.
Yeah, thanks, Eric. And on that score, you know, as you said, personalized medicine is the work geared toward helping find treatments that help each individual person, depending on the person's individual characteristics. So not the same treatment doesn't work for everybody. And it's important, I think, to recruit for studies that are, if you want to have a wide effect on people, and be generally helpful from a wide range of past health conditions that lead into the mental health challenges that people experience. So here's a question from Kimberly Allen in the audience. Kimberly Allen is asking, I'm a licensed drug and alcohol counselor, and I've worked with many individuals with a history of past usage and have affective disorders. In brain health and in terms of brain scans as one example, how is past usage of alcohol and or other drugs taken into consideration when researching the brain? Are patients with such histories generally excluded from such studies?
I can go ahead and take that, I guess. And so it's a great question. Generally, we track that information through various standardized measures. So we try to find out what their history of substance use is, how long they've used a certain substance, how frequently they used it, how much of it, etc. And I would say it depends on the study. Some studies might exclude individuals with a past history of substance use disorders. In general, I personally try not to do that unless there's a very close, you know, maybe they just recently stopped using, for example, or there might be some contraindication between, you know, using alcohol and like the treatment, for example. But in general, we try to keep those people included, because I think it's important to recognize that that is generalizable. That gives us an idea of what it looks like in the real world person, because these substance use disorders are often co-occur so frequently with depression and anxiety and bipolar.
Yeah.
And sorry, Brandon, I can add to that, if that's all right, that with our work on psychological or behavioral treatments, and when we're often using functional neuroimaging before and after treatment in order to assess changes, similarly, we will include anybody, even if they've had a history of substance use, as long as they're not currently intoxicated as they go through our program. But I did want to add something, if I could, to the previous comment, because it was a really interesting discussion as well about, you know, the somatic techniques and for whom each of these will be most effective. I think a major gap in the research has been the combination of things like TMS or ECT with behavioral strategies. So, you know, most patients go through TMS for a period of, you know, weeks on end, maybe 6 weeks daily, and then they're done and treatment's over. And there's not usually a follow-up with, now that you're feeling somewhat better, what about learning some skills to prevent the future onset or relapse? Because depression in particular tends to be quite a relapsing condition. And similarly, following ECT, we're doing a study right now on that topic, but it is interesting to me that that's such a gap in the research of how to combine these things.
Wow, that's fascinating. How behavioral interventions can add on to somatic interventions and to kind of extend their usefulness. I kind of had a similar experience when I used cognitive training back in the 1990s. It's not a somatic intervention in the sense that it's not waves being put into the brain, but it does change the brain through neuroplasticity, the ability to strengthen neural circuits in the brain through neuroplasticity. And then by practicing the functioning that I learned, my brain learned, through the cognitive training, I was able to strengthen that over time through behaviors. And so I can see how that effect can snowball. That's really great to hear. That's widely applicable. We do have a couple more questions here from the audience, well, several questions in the audience, but a couple that are kind of relevant here. This is a question for any panelist. This is from Garen Staglin, chairman of One Mind. We're beginning to understand that the gut and our biome and associated inflammation can be a factor in influencing mental illness. Can you explain how? That's a tough one. Anyone have
Who wants to take on the gut microbiome? Or at least let's start by telling us what it is. Who can tell us what the gut microbiome means?
Yeah, I can. I'll go ahead and I'll take a shot. And so I'll just preface this by saying this is not my area of expertise at all. But what I do know is the microbiome is essentially each person has their own unique makeup of gut microbiota, which are all of the microorganisms that live in the gut that actually, typically assist with digestion and the absorption of nutrients and that kind of thing. And so the microbiome would be the whole collection of unique gut microbiota that a person might have. There is a lot of emerging research looking at the relationship between gut functioning and the microbiome specifically and mental disorders. And I will say that that's a very good question, and I don't know the answer in regards to how it might specifically promote or prevent mental illness. There's a couple hypotheses I could put out there that I think people are investigating, and one is over the course of development, that the microbiome that a person has when they're very young, for example, will dictate the degree to which they can absorb certain nutrients from their food. And it's possible that people that have a certain microbiome may be deficient in properly absorbing certain nutrients from their food, which could then contribute to a brain development change that might lead to a future mental illness. There's also a strong interconnection between the nervous system of the brain and that in the gut as well. And so there's a lot of reciprocal communication that occurs there between the two.
Okay, thank you.
Let me add one detail, Brandon, that current science suggests that there may be as many bacterial cells in a person's gut as there are human cells that constitute our bodies. And these bacteria act on all the foods we eat and then determine the types of signals that get sent to the rest of our body in terms of metabolism, the immune system, and other organ systems, including the brain. I would say this falls in the area where Victor was talking about before, a type of investigation that holds great promise, but needs a lot more investigation to cipher what is truly actionable information to help human health. I'm sorry, I'll turn it back to you, Brandon. Go ahead.
No, that's great. Thanks, Eric. I think that's a question a lot of people are interested in. I know at least one other audience member is interested in the area of nutrition and how that relates to mental and brain health. So thanks for going over that. Question here from Michael Chakim. This is a question, looks like it's for either Dr. Fonzo or Bayer. Thank you, Michael, for your question. How about the effects on the amygdala of long periods of general anesthesia or coma and amputation, like some recovering from COVID-19 after having ventilators removed?
Okay, so that's a very good question. If I understand correctly, how could a long period of being in a coma, for example, or being under anesthesia impact the amygdala? That's an excellent question, and I will say that I don't know of any studies that have looked at that specifically. so one possibility is that the amygdala is very important in detecting things in our environment that might be important to us, like for example a snake. We would be important to detect that so that we could avoid it and not get bit. And so it's possible that being in a coma or being under anesthesia might reduce the function of the amygdala because of the fact that consciousness is not present to be able to be aware of the outside world. And so we do know that that is one important function of the amygdala. It's an excellent question, though.
Greg, I would just add to that. What was mentioned earlier by Brandon about neuroplasticity and usage. Prolonged coma is going to affect how the brain strengthens. Basically, use it or lose it. If you're not using these circuits actively, if you're in coma for a long time, you're not going to be getting these external signals in the same way. Consciousness isn't going to be active like you just mentioned, and that's certainly going to influence the way your brain and certain emotive centers like the amygdala are able to respond to these stimuli.
Mm-hmm. That's so true. Use it or lose it. Brain is like a muscle in that sense. A couple of questions that are, relevant for primarily Michelle, it looks like. Can the STAND program be available to other community colleges in California? David Brown asks.
We would love it to be available to other community colleges in California, particularly rural community colleges, because, again, the issues of access to mental health care are of paramount importance there. It's all about orchestration. And so we're currently working with the Chancellor's Office for Community Colleges in California to see what can be done, and would be very, very open to further discussion about that.
Thank you. Eric, you wanted to ask a question?
Yes, I wanted to go back to some of the earlier themes that Victor highlighted because they capture several questions that audience members asked. For example, Stephen McNally asked a question about parity. We've heard about mental health parity for decades now, but it's been so difficult to achieve. Why is that, Victor? And others can add in as well, but we'll start with you, Victor. Why just has it been so difficult to achieve equity in care for those suffering with mental illness?
I think this is a broader question about all of healthcare in our country and globally. I think equity is a major issue. But when you look at not only access to care, which is clearly an issue of equity, but also the health status of different populations, we do know African Americans and minorities and people of color have worse, more risk, more comorbidities, worse outcomes. I think that is, in fact, many people think is rooted in a degree of structural racism, bias of our community, which in fact perpetuates some of this problem. So I think all these issues are linked, and until we're able to address all these issues, it's going to be very difficult for us to move forward. I think at the end of the day, the challenge we face in this country are more social, economic, and other issues which influences health outcome, economic opportunities, etc.
Thank you. And in a related way, the same individual, Stephen McNally, had a specific suggestion about helping us cross state lines with respect to healthcare, so that if there are a larger number of doctors or nurses or other healthcare practitioners, or even more informally trained healthcare givers, as one of the other questions earlier in the program had alluded to, how can we get those individuals, how can we harness those individuals from one state to another where there might be a particular need?
Yeah, let me say the following. COVID has certainly relaxed a lot of these restrictions, particularly the use of telehealth, where it used to be you can't practice across state lines. I work closely with the Federation of State Medical Boards. They are interested in re-examining many of these issues. But you have to remember, these are state medical board dependent in terms of licensure and ability to practice. So the Federation brings these regulators together, and there is now a lot more receptivity to change. I think this also applies to healthcare workers, whether you have to be a medical physician or nurse or health professionals, practicing at the top of their profession. And in mental health, you really need this, allowing, in fact, non-medical, non-physicians to practice mental health, at the level where they are really trained to do. But that obviously is the idea of distribution of care, which I think is very much needed in our country.
Thank you, Victor. Brendan, are there other audience questions that we should answer?
Sure, there's one more. This is related to the social determinants of health and the question about, also a little bit of the question about the gut and nutrition. How does heart health impact mental health? The mental health is not just centered in the brain, but it's a whole body thing. And is there research being done to address brain health as a whole body issue?
Nobody else wants to take this on?
Victor, you're the cardiologist, Victor, so I think we defer to you.
Well, I think it's already been said that to begin with, there is close connection between the brain and the heart, in terms of neural inputs, neuroregulation. Usually you think it from the point of efferent signals going to regulate your heart and blood vessel function, but it's clear that the direction also goes upwards in terms of signaling to us how you influence the brain and vice versa. So there's a good amount of work being done there. Certainly we do know that in the older population, dementia, vascular dementia is common, and clearly that hypertension, small vessel disease, large vessel disease can influence cognitive function, if not lead to, quote, mental illness. I think the less known is the connection of many of the various illnesses we talked about, which are mood illnesses, bipolar and other, schizophrenia, much less known about how they connected with each other. But there's no question there's a link between physical and mental health, and the link between cardiovascular health and mental health. Most of these are actually expressed in the form of dementia or others, or expressed conversely in the form of diabetes, obesity, etc. So I think it does come back to the whole idea of comorbidities and the risk factors which you are all exposed to. And it does come back to Brendan's question about equity. These are all interrelated issues.
Absolutely.
Thank you. And go ahead, Brandon. You were going to say something?
No, go ahead. Go ahead, Eric. What were you going to say?
I just wanted to thank all of our panelists for outstanding talks. Thank our audience for great questions. If we were there live, we'd give everybody a big round of applause. So let's do that in your own homes. Please thank everyone. And Brandon, thanks again for having us here.
Absolutely. Yes. Thanks, everybody, for participating in our symposium today. Thanks to all the speakers. And thanks to you, dear viewers, for being here today and asking your fascinating and very important questions. And I hope the scientists and the answers that have come out have inspired you as much as they have me. As we said, 2020 has been a year of great challenges and trials in our society and in our own lives. And the pandemic has heightened the distress and trauma that so many people experience. That's why at our Music Festival for Brain Health this year, we're hosting a Fund a Need to support 2 programs aimed squarely at these effects that we experience. Heroes Health is an app-based program to help frontline healthcare workers track and protect their mental health, while they in turn care for all of us during the pandemic. And Aurora, on which Heroes Health is based, is the largest study of trauma and what happens to the brain after trauma, and how to personalize treatments for trauma ever devised and executed in our society. If you'd like to support either of these programs, and any contribution of any size is indeed welcome and deeply appreciated, please text Brain Health to 44321. Thanks, everybody, and please share what you've learned today far and wide with everyone you know. Really appreciate you being here. Thank you.